We now move ahead to the next session that features Dr. M. Khalilullah oration. This year, this oration is being conferred on Dr. C. Narasimhan. Is Dr. C. Narasimhan. He is currently a senior consultant electrophysiologist at Care Hospitals in Hyderabad. This morning, Dr. Narasimhan joins us to deliberate on granulomatous myocarditis, diagnosis and management.
Good morning, chairpersons, ladies and gentlemen. At the outset, I would like to thank Dr. Chopra and the organizing committee for this kind invitation. I am supposed to speak on granulomatous myocarditis, which is a common presentation that we see, which presents as ventricular tachycardia. Over the next 15 minutes, I would briefly talk about the background and when to suspect this clinical entity, how to treat and what is expected, and we have a large registry of patients with granulomatous myocarditis. What have we learned from this? These are the pioneers who have described one sarcoid and the other the tuberculous granuloma. If you were taught in medical school that in a patient with dilated cardiomyopathy suspect tuberculosis, we used to never consider or even entertain that as a possibility. We have realized that patients with isolated cardiac sarcoid very often go unnoticed, and the only manifestation can be a sudden cardiac death. Similarly, there are isolated reports of myocardial tuberculosis which have presented as ventricular arrhythmia, which have been picked up post-mortem and not clinically. We have been tuned to thinking of sarcoid as a multi-system granulomatous disease, but isolated cardiac sarcoid is a different clinical syndrome where predominantly you have cardiac manifestations and they are seldom diagnosed ante-mortem. Now let me start off. There is no better way than giving an example. This is a chemist, 35-year-old salesperson who came to us with ventricular tachycardia of this morphology. Physical examination was normal, echocardiogram was normal, normal coronaries. He underwent a catheter ablation of an RV outflow because everything was normal. 2 years later, he presented with a left ventricular VT coming from the left ventricular base and the inferior wall of two different morphologies. And then we investigated this patient. He was found to have a mid-septal scarring in the gadolinium enhanced MRI, which was extending to the right ventricular outflow tract, and high-resolution CT revealed plenty of mediastinal nodes, biopsy of which revealed non-caseating granuloma with minimal amount of caseation in the center. So you're left with the diagnosis: is sarcoid, is it tuberculosis, or is it anything else? Skin test for tuberculosis was positive, PCR was positive, mediastinal node culture for acid-fast bacilli was positive. This patient's VT completely resolved and the episodes regressed with anti-tuberculous therapy and beta blockers. We saw this entity way back about 10 years ago and described this as an atypical clinical manifestation of idiopathic, so-called idiopathic VT. And this prompted us to investigate most of these patients who present as ventricular tachycardia for possible tuberculosis or sarcoid. Now, this is a brief investigation protocol. In every single patient, first is to decide, is there a scar or is there an ongoing inflammation? By doing a contrast-enhanced MRI, high-resolution CT chest, or an FDG PET in patients who have implanted devices, we resort to PET CT before we think of doing an MRI, and then biopsy of the involved node. Then to determine the etiology of granuloma, we send them for all tests for tuberculosis and fungal cultures. This is about 6 months ago. We have a cohort of about 92 patients and with preserved ventricular function with a decent follow-up of about over a year in most of these patients. Clinical presentation was unstable VT or stable ventricular tachycardia or ventricular dysfunction. What is sad is the last patient, in fact, who came for a cardiac transplant, the explanted heart is full of tubercles. Had we diagnosed this 5 years ago, instead of giving him more and more dobutamine, we would have prevented this malady of dilated cardiomyopathy. Now, the paradigm shift in thinking is we are used to diagnosing this entity by doing an endomyocardial biopsy. If you go through pathology literature, the site where we do a biopsy is seldom involved. This is a site where we do an endomyocardial biopsy. And that site is seldom involved by focal granulomatous disease, either it's tuberculosis or sarcoid. That explains the poor yield from endomyocardial biopsy. The commonest site of involvement is the posterobasal wall with tethering of the mitral annulus and causing an eccentric mitral regurgitation. We had done about 15 biopsies in the first 15 patients. Since the yield was very poor, we stopped doing endomyocardial biopsy and moved on to biopsying the paracardiac nodes for diagnostic yield. If a patient had an AFB stain or culture that was positive, it was labeled as myocardial tuberculosis. If the stain culture and skin test for tuberculosis are all negative, we start treating them as cardiac sarcoid. But if they have a skin test that is positive, we have this as an overlap syndrome. In fact, it is well described in pulmonary literature of what is known as tuberculous sarcoidosis, where tubercular antigen precipitates a sarcoid-like reaction. And this is our diagnostic algorithm. So over the past couple of years, we have had close to 92 patients. 44% of them are cardiac sarcoid, and about 40% of them were proven myocardial tuberculosis, and in about 20% it was an overlap. There was a diagnostic uncertainty. We ended up treating as both. And this is the yield from myocardial MRI, where the yield is the commonest abnormality is the mid-myocardial scarring, and sometimes posterobasal epicardial scar is noticed. In very early stages, this can be falsely negative, but you may still pick up T2 weighted imaging showing myocardial edema as a sign of an inflammation. 2 years ago, we published our results, and again, it confirms this is an international registry of sarcoid showing that the predominant site of involvement is the basal septum. Regarding myocardial tuberculosis, you can draw a similarity similar to aortoarteritis that we see in clinical practice. You don't have an ambiguity about the skin test in these patients. When they develop a skin test positivity that's grossly necrotic and more than 30 millimeter generally, and they are hypersensitive to this antigen. What we have realized is that radiofrequency catheter ablation is temporarily, it's got very minimal effect in the acute phase of the disease because it's multicentric, and getting rid of the one focus doesn't solve the problem. And therefore, very often initial therapy is to diagnose the underlying granuloma, cause of the granuloma, and treat them with antiarrhythmic therapy. And we follow them up. This is a patient with a initial myocardial tuberculosis with a very high uptake. Following 4 months of antituberculous therapy, complete resolution of the myocardial inflammation that you see with FDG uptake on PET scan. Now, parallel to this resolution of myocardial inflammation, you see a dramatic fall in the VT frequency over a period of time. It takes about 3 to 4 months for the VT episodes to regress, but if you wait patiently, the VTs progressively come down and the VT episodes, ventricular tachycardia, resolve with antituberculous therapy or steroids, as the case may be. This is an unfortunate story of an ophthalmologist who went with an idiopathic VT as a diagnosis in 2007. Initially tried an ablation, then goes on to develop an ICD was implanted, develops an LV dysfunction, and then he comes to us now with advanced heart failure, EF of 20% for a possible cardiac transplant. At this stage, when we do a biopsy, we realize that he has a cardiac sarcoid. Had this diagnosis was made in 2007, all these morbidity for this patient could have been prevented. Now, as a clinician, how do you suspect this disease entity. One of the common things that is taught in clinical medicine is to immediately send for serum ACE levels. Serum angiotensin converting enzyme inhibitor, ACE levels are seldom useful in this entity of myocardial sarcoid. They are extremely useful in pulmonary sarcoid. When you go across the street, our pulmonologists, they have a very high yield. For myocardial sarcoid, the yield is very poor, less than 10%. So do not rely on serum ACE levels. There are subtle clues on the electrocardiogram and echo which will give you a possibility of this diagnosis, and varying VT morphologies, pleomorphic VT morphologies should make you suspect. Now this is one of the results of a study, one of our fellows have put it up. If you see in the presence of ventricular tachycardia and a normal heart, fascicular blocks, PR prolongation, or what is known as fragmentation of the QRS, I'll show you an example, you should suspect granulomatous myocarditis. One is in a patient who has got non-ischemic cardiomyopathy and who presents with recurrent ventricular tachycardia, suspect this disease entity. If you have concomitant conduction system disease, you should suspect this disease entity. Or when you have cardiomyopathy and AV blocks, you suspect this disease. When you see an ECG like this, highly fractionated, fragmented QRS, you should suspect that you are dealing with a granulomatous myocarditis. So, ladies and gentlemen, Chairman, I would like to conclude by saying sustained monomorphic ventricular tachycardia may be the only manifestation of myocardial tuberculosis or cardiac sarcoidosis. And several clues, simple clinical clues like fragmentation of the QRS that you see, basal septal thinning on the echo, hyperechoic papillary muscles, these are all subtle clues that will tell you that you're probably not dealing with an idiopathic VT and you need to investigate further for diagnosis. The most important message is if you diagnose this disease early, you can prevent progression of disease and myocardial dysfunction, heart failure and cardiomyopathy and frequent recurrences of VT. I heard Dr. Didwania commenting about the rampant use of devices in a developing country. If you don't diagnose this disease early on, when they come with a diffuse bag of fibrous tissue, then they will be going through a VT storm and nothing is going to work. So the key to the problem is early diagnosis, and key to that is suspicion, high index of suspicion of this disease entity in every single patient with VT or AV block that you see in clinical practice. Thank you very much for the patient listening.
Ladies and gentlemen, we'll now have one comment from the chairman and then we'll move on with the presentation ceremony.
Ladies and gentlemen, this is a very prestigious oration named after none other than Professor Khalilullah, who had a tremendous contribution in the field of electrophysiology. When we were students, we heard only about Khalilullah and EP. And I am sure we have many EP people, and we are very, very fortunate that we have a person of such a high caliber, C. Narasimhan, who had enormous contribution in the electrophysiology and the cardiac arrhythmias in the real world. We are honored, sir, for your presence, and I'll request the chairperson, all the three chairpersons to come forward, and I request Dr. S.K. Parashar to kindly come on the dais and bestow upon this M. Khalilullah's oration to none other than our own Professor C. Narasimhan.
Ladies and gentlemen, Dr. M. Khalilullah oration has been conferred on Dr. Narasimhan. Many congratulations, Dr. Narasimhan. We'd like to thank our chairpersons